I have 5 minutes to cover this recent publication. It was just accepted this past week, where we looked at the overlap between Takotsubo and SCAD in the iSCAD Registry. And I want to thank all of you patients who have been part of this and who've allowed us to participate in your care, and all of our co-investigators. Dr. Sangavi did a really nice job outlining some of the overlap between Takotsubo and SCAD. We recognize that these conditions occur frequently and more commonly in women. And if we think about the underlying background, both may have relationship to emotional stress. In Takotsubo, perhaps neurological, microvascular, and in SCAD, more mechanical, arterial, and neurological. So they do have these shared clinical features as well, which is why they often are in the differential diagnosis. If we look at the patient profile, we know that the average age of a SCAD patient is about a decade and a half younger than the average age of a Takotsubo patient. SCAD patients, as we well know, are more likely to have some non-traditional risk factors versus the typical Takotsubo patient will have more of the traditional risk factors likely related to their advanced age. But despite that, there are often some shared clinical similarities. When we first began the MGH multidisciplinary SCAD registry in 2015, very early on when reviewing angiograms, we noted that there appeared to be often a hinge point when we would see SCAD in association with a ventricular wall motion abnormality that was really out of proportion to what one would expect for an open artery or a non-obstructed artery. And so we kind of developed this concept of the hinge point, mentioned it in Dr. Duran's paper of 2019, and then thought about the pathophysiological feedback loop of SCAD triggering Takotsubo and Takotsubo triggering SCAD. Now, you will have access to these slides, so I'm going to kind of fly through this so we can focus on some of the data. When we looked at the iSCAD registry of 259 patients in this cut of the data, we found that in 17% of the patients, there was a ventricular wall motion abnormality that appeared to be very similar to what we would see in Takotsubo, and often was disproportionate to the degree of flow obstruction in the associated vessel. For the purposes of our recent accepted publication, we actually had to tone down the language, and instead of saying Takotsubo-associated SCAD, the reviewers requested we use the term Takotsubo-like ventriculographic pattern. That's a lot to say. However, clearly using the angiographic laboratory of the Perfuse lab in Boston with great expertise, again, 17% of our SCAD patients had evidence of Takotsubo. 52% presented with STEMI. In the majority, the LAD was involved. However, as I will show you, in over 50% of the cases, there was completely normal flow in that vessel. And we did see about 66% with evidence of left ventricular systolic dysfunction or pump function with an ejection fraction under 50%. This is our paper in the AHJ+, and as you heard earlier today, these open access papers are a gift because it means anybody can read these papers. Quickly looking at our patient characteristics and clinical presentation, from the perspective of patient characteristics in those who had the classic pattern of Takotsubo-related ventriculopathic pattern, or those without that, or a less typical pattern, clinically, the features were very, very similar with regard to patient demographics and underlying triggers and risk factors. However, when we looked specifically at the clinical features related to the type of presentation, ST segment elevation or STEMI was much more common, significantly more common in those with the Takotsubo-like pattern. And as you can also see here, obviously, with regard to the type of symptom, unstable angina, a little bit more common. It's not common in SCAD typically, but in those that did not have the Takotsubo-like feature. When we looked at coronary and left ventriculography, again, those with this pattern much more likely to have reduced ejection fraction, LAD more commonly involved. But interestingly, if we looked at TEMI flow grade, and for those of you that are not clinicians, that's where there is an abnormal filling of a vessel. In 51%, it was abnormal, but that means in 49%, it was completely normal despite there being an appearance of a SCAD. We also saw that looking at the type of SCAD, there wasn't a significant difference, whether type 1, type 2, type 3. But again, both abnormal flow and abnormal perfusion grade, suggesting both some type of underlying microvascular endothelial associated factor. Something was causing that blood flow to be obstructed to that abnormal appearance. And then interestingly, despite the LAD or the artery that runs down the front being the most commonly affected, we saw wall motion abnormalities underneath the heart as well. So it wasn't just LAD involved anterior apical abnormalities. We saw abnormalities in the other parts of the heart muscle as well, as you can see here. Interestingly, when we compared those with the Takotsubo-like pattern to those without, we saw more in-hospital events compared to those without. So the red is those with this pattern, the gray is those without. And these included more recurrent MI, more new arrhythmias that occurred during the hospitalization, and heart failure requiring diuretics. So when we compare those who had SCAD without this pattern and SCAD with this pattern, we clearly the MACE or the in-hospital events, 34% in those with the pattern versus 13% in those without, driven by higher incidence of new arrhythmias, including ventricular tachycardia, AFib, and heart failure requiring diuretics, yielding an odds ratio of 5.74. There was 5.74 higher likelihood of major in-hospital events. At discharge, we found those that had the Takotsubo-like pattern were more likely, in addition to being discharged on aspirin and a beta blocker, to be discharged also on an ACE inhibitor or ARB, likely to manage their reduced left ventricular pumping function that was seen more commonly in this group. So in conclusion, 17% of SCAD patients from the iSCAD registry exhibited this pattern consistent with Takotsubo-like cardiomyopathy. They were more likely to present with ST segment elevation infarction, to have LV dysfunction. Type 2 SCAD was seen more commonly, but not statistically significantly. LAD was more commonly involved, and there was an increased incidence of in-hospital events. And with that, I will conclude. Thank you.